Sir, we are on live.
Good evening and welcome you all to this masterclass series on transcatheter aortic valve replacement. This is the second series and this is organized by Dr. Sridhar Kasturi sir along with the Sunshine team, Dr. Shailendra Singh, Dr. Vijay Kumar Reddy, and also myself. I'm from Kaveri Hospital, Chennai, but we do work together for most of the transcatheter cases at Sunshine. And we also have Dr. Chaim Dannenberg from Israel. He doesn't need any sort of introduction. He's well known in the interventional cardiology community, very experienced with the transcatheter therapies and all aspects of interventional cardiology. We welcome you, sir.
Good to be with you and looking forward for an excellent session today.
And we have a very senior, experienced panelists and speakers today. First presentation will be by Dr. Rahul Gupta from Mumbai. We welcome you, Dr. Gupta.
Yeah, thank you very much.
Again, more than 20 plus years experience and experience in all aspects of interventional cardiology and also transcatheter valve therapy. Done more than 50 cases transcatheter valves, and he'll be talking about the hemodynamic advantage of supraannular valve in valve. We'll probably start with your presentation, sir, and before each speaker, I will introduce the speakers. And obviously, the attendees, if they have any questions, you can put it in the chat box or you can raise your hand at the end of the presentation so that all the panel members and Dr. Dannenberg will take the questions and we'll answer it as much as possible. So we'll have a good program. There is a good mixture of cases for us to learn from each other. Yes, sir. Up to you, Dr. Rahul.
Yeah, so thank you very much for having me here, and good evening, everyone. I hope my slides are seen and I'm heard well.
The slides are seen. Need to go to slideshow.
Yeah. Okay, so today my topic is hemodynamic advantage of supraannular THV in valve cases. So let me, I just introduced what is the scenario these days. Why do we get so many valve cases? Then I was going through the literature and 10 commandments for valve, and I would, like to have comments from Dr. Chaim for how to approach these cases. So go short in those. Then study about PPM, I think is an important aspect, and why supraannular THV system is something which is to be considered in valve. And then maybe conclude with one case scenario, which was a little tricky. So I'll present that. So I think the recent trend demonstrated an increase in the proportion of bioprosthetic surgical valve in aortic valve replacement. If we look at the US data, and I think there are similar studies where the percentage has significantly increased. Now, while we know the advantages of bioprosthetic valve, but they are prone to structural degeneration, and some studies have shown as high as 40% rate of reintervention at long-term follow-up. Now, but we all know that it offers a less expensive alternative for these high-risk patients with a mounting global experience and excellent results. But this is a learning curve, and this is the time where we can discuss and debate about different techniques. And it offers some important pitfalls that may be quite life-threatening, like coronary obstruction and all. With the TAVI now approved in low surgical risk patient, every aspect has to be considered while implanting aortic valve in valve to get the best short and long-term outcomes. Now, I think most important part is know your patient and their valve. This is most important. So I'll go into discussion of this. Then evaluate for the pre-valve and valve prosthesis patient mismatch, because if there is a pre-existing prosthetic PPM, then it leads to worse outcome as compared to those who don't have. Identifying the case at the risk of coronary obstruction so that we can apply those different kind of techniques which can help us overcome them. We have to exclude certain cases and then select optimal transcatheter heart valve for our particular case. And today we are going to discuss that how supraannular valve is better. Then position the transcatheter valve heart optimally, because if we place a supraannular valve quite deep, it will become annular and may lose its advantage. We can discuss in the discussion about the valve fracture, great ends and good hemodynamics. And these different procedures are there, basilica, chimney snorkel, shortcut catheter, and whether anticoagulation should be done in valve cases because they are more prone for thrombus. And I think meticulous follow with echocardiography is required. If you look at the failure modes of bioprosthetic valves, I think wear and tear, calcific degeneration are the most common reasons for bioprosthetic valve failure, in addition to pannus, endocarditis, and thrombus, as we see in the different pictures over there. But knowing the valve is extremely important, because sometimes these are the patients who are coming to us after 10 years. They may not have the data, and they may not have the operation notes. Therefore, identifying the valves is important, understanding how the what kind of valve it is, stented, without, stentless valve, and what are the different the composition of the valve, the stent pose, the base ring, the silicone base ring, and all these components it is good to understand, and whether it's a stentless valve, bovine pericard, because we are going to get the inner diameter based on how the valve, which kind of valve we are using, and we'll just look into that chart also. And the surgical valves are different. For example, this is just for demonstration that markers may be located in the crown, in the swing ring, or they may be located below the swing ring. So, and we also need to understand the fluoroscopic image of bioprosthetic valve. There are, these are available in valve identification guide, so that it can help us to identify if we don't have the nodes. And then these are dimension of surgical stented bioprosthetic. I think this is important to understand for, in terms of calculation. So we have the A as the stent outer diameter, we have the B as the internal diameter, then this is the swing ring outer diameter, and then we have the stent height. So all this information can be helpful in deciding the size. So this is just an example that same site was still different. So we have different size 21 valves, and we look at that this is 21 millimeter, but if we look at the stent inner diameter, it may vary. So as we see this, the third column, we'll see that these inner diameter may be different. And we all know this Puppet, I think it is quite useful, valve in valve app, but identifying the valve and then their inner diameter is very important in identifying the correct size. So I think whenever we are planning the case in the valve in valve procedure, patient selection is extremely important. If there's a concomitant significant PVL, we have to think about that, whether we need to close it with the device, and if it's not securely fixed in the native annulus, then it can be risky, and partially detached leaflet embolization can be risky. Valve identification can be done as we just discussed, and CT is definitely very, very useful. And valve sizing appropriate to so that we can select the correct THV. Now, the key performance indicators for valve in valve are flow to the coronary arteries, the paravalvular leak, and the hemodynamics, which I'm going to discuss in the short. We'll keep more time for discussion, so I'll try to complete my thoughts about things. Now, hemodynamics will dependent on the effective orifice area and the pressure gradient. And ppm is an important part, because ppm occurs when the EOA of a normally functioning prosthesis is too small in relation to patient's body size. I went through different literature, and what I found is that ppm exists in about 20 to 70% of surgical implant and has negative impacts on the regression of LVH as well as long-term survival. And avoiding ppm is key to improved survival. So we have to make sure that we can avoid ppm as much as possible. A larger EOA allows, and why it is so important, because a larger EOA will allow for less workload on the ventricle, improving the LV mass, regression, and survival. It will give good hemodynamics, immediate relief from AS symptoms, and it is also related to the durability. So a larger EOA provides improved flow, less resistance, and better long-term durability, as we want that our valve should last longer. Now, this is the rate of elevated gradient, 30-day mortality, and 1-year mortality stratified by the presence of severe pre-existing ppm required. So if there is a significantly elevated gradients after VIV, the mortality, whether it is 30-day or the 1-year mortality, is on the significantly higher side. And also, if there is a pre-existing severe ppm, all-cause reintervention is going to be on the higher side, as we are seeing in the graph. And if we use a balloon expandable versus supraannular design, we find that the supraannular design has a lesser need for reintervention, as we can see in this graph, because of the better effective orifice area. So why supraannular THV? Now, the line indicates the level of working portion at the bioprosthesis. We can see that the supraannular valve design moves the leaflet above and is unconstricted by the native annulus, and the interannular valve design is internal to and constrained by the native annulus. And this will definitely have an impact on the EOA. So a supraannular valve keeps the working portion of the valve above and unconstrained by the annulus and will provide a better EOA. Now, this is a comparative hemodynamics. It's not head-to-head, but if we look at the hemodynamics EOA at 30 days, the best EOA which we can get is with the supraannular design most of the time with the Evolute and CoreValve platform, while as compared to the other THV systems. And I think it maximizes the blood flow, and that's what is helpful in improving the hemodynamics. So I think hemodynamics are one of the most important parameters when considering TAVI in failed bioprosthetic valve, and supraannular design decouples the TAVI leaflets from the failed bioprosthesis and thus prevents the lower pressure gradient specifically for small bioprosthetic valves. Better durability of the valve is dependent on EOA, especially for valve-in-valve cases. So I think, whenever I think we get a smaller valve and so we want a better EOA, supraannular valve will always have an upper hand. This is, and most of the cases which I have done were with this supraannular design. So I've tried to complete it a little faster, some theoretical thing. A case which was a little tricky I've done about 7 cases of valve-in-valve. And this is one of the case which was very early during when I started doing TAVI. So I thought this might be a good discussion also. So I'll just go through the case a little faster because the difficulties and the challenges which I have faced. So this was a 68-year-old male, and he had a bioprosthetic valve 2009 with Paramount 19, and he had severe symptomatic stenosis, restenosis with aortic valve gradient of 88/46. EF was preserved. The anatomy, whether it is the VTC distance, all other things were okay. The coronary heights and the sinus heights were okay. The only thing, one of the challenging thing was quite a horizontal aorta in this patient, and there was a septal bulge. So this was almost a completely horizontal aorta in the aortic root in this patient. And the distance, surgical valve to coronary distance, this is an axial view, was quite sufficient, and the chances of coronary obstruction looked very less. And this is a virtual valve deployment design, the strategy which was done. And the challenges which I faced during this was, the procedural consideration was that this is a small surgical valve, so what should be the choice of THV? So I decided for the supraannular. It was a horizontal aorta, septal bulge was present. The valve to coronary distance was okay, and positioning, we have to position as superficial as possible. But then there can be issues of popping out and all those things which I have faced in this case. So this was just to show you the valve was quite horizontal, and the wire crossing was little tricky in this case, and it was a completely in the horizontal and the surgical valve. So I tried different catheters, and finally it crossed with the help of the JR4, and the wire was pressed. This was done with with TE guidance in those times, and valve was getting stuck at the valve frame. So little maneuver was required in this place also. It was getting stuck. And the difficulty which I faced during this was positioning. Either it was going too deep or popping out, and despite pacing and all, this was happening. So these are all the images. I'll not go through them right now because we should have some time for discussion. And so these are various attempts. Either it was going too deep or it was quite superficial. I'll show you the final picture. So this was the final attempt. This was released, and the post-deployment T was okay. There was a hemodynamic, the check was, so it was not appropriate. There was still significant gradient. So it was post-dilated with ZMAD 18/4. and the aortic valve gradient reduced. It was not reduced to 15, but it was not that satisfactory. Finally, this patient, this is the final shoot. This patient did well, but the gradients was a little higher. So with the international proctor, we went ahead. We called him again, and we went with a very aggressive post dilatation. And after this patient has been doing fine. So I think this is just the case for discussion if we want to discuss about it. And I think in this case, horizontal anatomy prevented an ideal placement of THV at level 0 or 1 despite multiple attempts. And on the follow-up, this patient has been doing up after the second dilatation. So thank you very much, and I hope we can discuss now.
Thanks, Dr. Gupta, for a wonderful presentation. I think that the case can teach us a lot. The case that you showed at the end can teach us a lot. My first advice for such a case would be to use a stiffer wire. This is a case for a Lunderquist, because otherwise, and as you could actually see, you couldn't become coaxial with the valve, and that was the main problem. You either dived too deep or popped out. And in such a case, in any case, even not in a valve in which the aorta is horizontal, I would definitely advise for a Lunderquist. And then there is always the question: should we fracture the prosthesis? It's very hard, and as you showed so nicely, it's very hard to cross small bioprosthesis, and we know that the residual gradient, and I will touch on this on my presentation, is an issue. And in such a case, I don't know the potential risk for a patient prosthesis mismatch. We can calculate this by actually knowing the body surface area, but definitely there is a place to consider balloon fracture. But yet, and then comes the question: should we do it prior to valve deployment or afterwards? Anyway, I think that the message that you conveyed so nicely is right. In valve, especially in small valves, go for a supraannular, meaning the Evolute platform. Try to implant as high as possible. Then you actually gain the benefit from the supraannularity, and then indeed consider whether we need an additional, either just balloon post-dilatation or even balloon fracture. I think that the supraannularity issue is so important, especially in those small valves. In India, as well as in Israel, these are the patients that we're seeing. We don't see many patients that got a surgical valve with a diameter of 25 or 27. Patients that we do see are indeed the 21 to 19. And here the potential for patient prosthesis mismatch is huge. So more to come in this very interesting arena. We'll have to use supraannular, implant high, and consider various modifications even to increase the diameter.
Yeah, thank you so much.
Thank you, Haim. It's a fantastic case, Rahul, sir. And I think there's not one, there is lots of learnings and lots of difficulties. Horizontal, small valve, and issues all around, septal bulge, everything, because you want to have a good position, but the septal bulge will not allow it. You want to have a supraannular, but the horizontal aorta will not help it. So these are the sort of things we have to balance it. As Haim said, Lunderquist people are using increasingly in Europe. In India, the use of Lunderquist is less. The reason for that is we are still in the early stages. Most centers probably have done 10, 20 or maximum 50 cases, apart from few centers. So there is always a concern about using a very stiff or wire Lunderquist, whether there will be any issues, perforations, other things. But I think I've repeatedly seen from Germany as well as from Israel, especially with the cuspal overlap and commissural alignment, Lundaquist has become the wire of choice, because once you place it and once you get the position, the valve will not move. So it stays there where you have position. But I think gradually we will get used to that with the experience that comes. Now, I will probably put this question later to him about the newer techniques for the valves with the leaflets placed outside, because Israel is pioneering in that with the shortcut picardia, sort of alternative to basilica. Before going to that, we have got some other colleague panelists who's just joined, and I will probably take some comments from Dr. Shailendra Singh and then Dr. Manik Chopra after that. Dr. Shailendra sir?
Very nice case presented, but it's really very good, very difficult to imagine, because majority of the valves that are kept in India are 19 or 21, and therefore they have a inbuilt annulus which is very small. So actually how to overcome that would be the prime concern when we are doing valve in valve.
Yeah. Dr. Manik Chopra sir has joined. Any comments from your side?
Hi, good evening, Rajram.
Hi.
I was just a little, I mean, there's one thing in these small valves. I would probably ask Haim to probably give more insights. If you try putting these higher, then there is, of course, the supraannularity is going to give you a benefit. But in most of these cases, we also probably think that we should post-dilate these valves, because there would be definitely some muck which is lying in between the valve and the outer frame, which you would like to push forward. At the same time, you also in your mind would probably be thinking about doing a valve fracture. So in such a scenario, what would you think would be the right depth? Would you still go with a zero implant, or would you probably like to put it slightly at 2 or 3 so that you have a chance to post-dilate? Or probably fracture, because 21 is definitely going to give gradients.
Yeah.
This is actually the key question. How deep would you go? And I'm trying to go very shallow, between 0 to 2. I know that once I'm anchoring well in the ring, and you need to be sure that you're indeed coaxial well, that you're not tilted. But once you're fully anchored in the ring, you can post-dilate, you can even fracture, and I'll show a case of fracturing in a very short while. And then comes the issue of the very stiff wire. The Lundaquist is a key for this success, especially in these horizontal orders. Otherwise, it's very hard. If you're not using a very stiff wire that would kind of straighten you to the ring, you will end up kind of tilted a bit too deep or a bit too high, and then it's very hard indeed. You're then indeed concerned whether you can post-dilate. You're afraid that any movement of the valve would cause him to pop. And therefore, I definitely advise you in those cases of small valves, of horizontal aortas, go with the Lundaquist. It's quite safe. You need to deploy it in RAO projection, of course, through a pigtail. Do it very carefully. It's not much more risky than using either the Confida Safari or the manually pre-shaped super stiff wire. So to increase the safety and efficacy of this procedure, you should use the double curve Lundaquist. This would add to the safety and efficacy.
Thanks a lot.
Yeah. That's a fantastic case, and obviously we will be having more discussions after Haim's presentation, because he's going to show a valve fracture in his presentation. Maybe at that time I will probably ask him about the newer techniques that's coming up from Israel on the shortcut device. We've also joined, now Dr. Shivakumar has joined. He's got huge experience with the structural heart disease and his congenital heart disease interventions and pulmonary as well. Welcome, Shiva sir. So now the next presentation is from my colleague, obviously, Dr. Manik Chopra, and sir leads the structural heart disease intervention at Narayana Health in Ahmedabad. He's done more than 150 plus cases, and is also a senior proctor for TAVI in India as well. So we welcome you, sir. And he's going to show us a case with difficult access and how managed successfully. Please, sir.
Yeah, thanks. I would try to share my screen. Okay, let me see if do you see my screen by any chance?
Yeah, we can see it.
All right. So this is my presentation. This is regarding TAVR in a challenging access. This gentleman is 70-year-old. Of course, this case is really not a very difficult access, I would say, but a typical everyday tricky access which we get. So it's about a 70-year-old male, ex-smoker, dyspnea on minimal exertion, NYHA class 3, and requires oxygen therapy due to chronic obstructive lung disease. Regarding past history, he is post-CABG, Lima to LAD, and RSVG to diagonal and OM for coronary artery disease, double vessel disease, 80% left main, 90% proximal LAD, 80% mid LCX. At that time, the ejection fraction was normal, and this was in 2011. Dobutamine stress echo was done in 2019, which was negative. There is a history of old cerebrovascular stroke, which was ischemic. And there's bilateral carotid artery disease, around 50-60% bilateral ICA lesions on MR angiogram done in 2014. Bilateral below knee peripheral vascular disease on vascular Doppler. Known case of COPD and requires repeated hospitalization in view of acute exacerbations. Diabetes, long-standing on insulin therapy, and diabetic nephropathy, diabetic neuropathy, lumbar spondyloarthropathy. MRI scan was done a few years back. So these are the comorbidities. On clinical examination, saturation was 91 to 92 on room air. Bilateral femoral artery pulsations were present, but there was a pulsatile painful swelling in the right groin, and there was a systolic bruit which was present over the local site. Lower limb pulsations, the dorsalis pedis was absent, but it was present on Doppler. It was absent on palpation, but present on Doppler, maybe due to calcification of the arteries. Blood investigation showed iron deficiency anemia, hemogram of around 8, microcytic hyperchromic anemia, low iron levels, 2-lobity negative, EGFR 45. ABG showed PCO2 retention with PO2 of around 70. ECG, it was sinus rhythm, PR of 150, QRS 120, and complete right bundle branch block. On 2D echo, it was high gradient aortic stenosis with mean gradient of around 50, peak of 90. All other valves were structurally normal. Mild tricuspid regurgitation, PA pressures of 50, moderate pH, mild MR, concentric LVH. All other chambers were normal. Gradient and diastolic dysfunction, and no wall motion abnormalities, ejection fraction 58%, normal RV systolic function, and IVC was normal and collapsing. Now, okay, and then, all right, so coronary angiogram was done from the right transfemoral route. It was done outside and before TAVR, and it showed triple vessel disease. RCA was borderline, and the Lima was patent as such, but the venous grafts were not hooked. There was a right femoral pseudoaneurysm post CAG, which was evident on clinical examination. We did an HRCT test and it showed changes of COPD, but a chest physician reference was made and there was a reasonable life expectancy with COPD. On CT scan of with TAVR protocol, you could probably see that it's a tricuspid valve, and the perimeter was around 70, perimeter derived diameter was around 22, LVOT perimeter derived was 21.7, and perimeter was around 68.3. And we could see that probably it is good for a 26 valve. And if we go lower down, SOV is it's quite roomy. STJ calcified, but average diameter of 24.7. Ascending aorta is not dilated. There is reasonable sinus height. If you see the LCC, it's 16.5 and RCC is 17. So coronaries are high. It's moderate to severe calcification, which is even, regular, uniform on all the three cusps. This is the coplanar view. It's almost like 0, 0, I would say, with not a very horizontal thing. The cusp, RL cusp overlay view, it is at 22/14. If you see the aortic arc, there is some degree of acute, I would say, angulation in the arc. Now, coming to the peripheral vessels, you could see that on the right side, on the lower aspect, there is a bunch of grape-like appearance, which is related to the right superficial femoral artery, and this is a pseudoaneurysm there. And if you see the common femoral artery lower down, it is 3.4/5.6. So I would say it is slightly stenotic there. But if you go higher up, it was around 5 into 5. Of course, I'm sorry, I could not show you the cross section at that level. The artery, the common iliac artery, as well as the other arteries, had reasonable calcification. And in common iliac artery, you can see on the right side, you can see that probably there is a reasonable amount of calcium, but of course it is good for at least a 5mm device. And then if you see the left side, on the left side, in the left common iliac artery, it's quite diseased, just below the aortic bifurcation. It's like 1mm into 2.9mm. So you could probably imagine that it's not good. The left side is not good for anything, probably, if anything, then from the right side, and a device which would have a minimum of the diameter for the access. Now, in summary, it was a high gradient aortic stenosis, post-operative CABG, reasonably patent grafts. I would say one of the grafts to the diagonal was occluded, but Lima to LAD and OM graft is patent. Borderline RCA disease, nothing to be done for the coronaries. NYHA class 3 predominantly due to aortic stenosis, normal LV ejection fraction, normal sinus rhythm, complete right bundle branch block on ECG. Regarding the comorbidities, infrarenal abdominal aorta and bilateral lower limb peripheral vascular disease, right femoral artery pseudoaneurysm post CAG, bilateral knee joint peripheral vascular disease, old CVA, bilateral carotid artery disease. The right internal carotid was diseased, 90% on the carotid Doppler. Iron deficiency anemia, microcytic hypochromic anemia with stool OBD negative. Known case of COPD, diabetes, diabetic nephropathy, and diabetic neuropathy. Now, regarding the heart team decision, I would say, since in view of post-CABG status and COPD, which is requiring oxygen therapy, of course, TAVR would be preferred, preferably from transfemoral route and under local anesthesia. Now, anatomical challenges, it was a critical left CIA disease, I would say left common iliac disease, and borderline and calcified iliac and femoral disease on the right side, right femoral pseudoaneurysm, and an angulated aortic arc. The other probable challenge would be right bundle branch block. So the proposed solution in my mind would be that probably let's compress the right femoral artery pseudoaneurysm by a USG probe before we go for TAVR. We double check during the TAVR procedure by an angiogram and plan closure with a covered stent after TAVR procedure if it was not occluded by the USG probe compression. We would prefer a system which is okay for the right femoral axis, since the left femoral axis is not good for any system. So the system probably which would come in my mind would be Medtronic ER, the regular one. Pro, because it would require slightly higher diameters, I would go with the ER. And then I would like to puncture high enough in the groove on the right side to avoid the lower diseased segment to be avoided, and would consider a USG or fluoroscopy guided micropuncture. I would probably think of using a right radial access upfront for the pictal, because once the sheath goes in, your aortoiliac disease is there, and the left iliac being critically narrowed, it's sometimes difficult to pass pigtail and other systems toward them. And of course, if the pigtail moves during the valve deployment, then probably repositioning this pigtail becomes very difficult. So then probably go with from the right radial axis, I would say, and then keep a safety wire from the contralateral side, ipsilateral, because if you go from the ipsilateral side, it is already diseased lower down. It's like 3 millimeters. And then you also have a segment of pseudoaneurysm there. Of course, the left side is also diseased. The left common iliac is also diseased, but it would probably allow passes of balloon. And if you require a stent to fix up on the opposite side, you can balloon the left CIA segment, left common iliac segment, and then probably take your stents lower to the right common femoral artery. So regarding the THV selection, since it was Medtronic ER, I would say that it would be 26 millimeter evolute arc, but it would fit that best because it's in the middle of the range for 26, so 20 to 23, so it was around 22, so I would say it in the middle of the 26 range. Regarding the pre-procedural other planning, I would say that we need to compress the right femoral pseudoaneurysm, we transfuse for hemoglobin to be optimized, optimization of lung condition, control of diabetes, and renal protective strategies for diabetic nephropathy. Regarding the TAVR planning, as discussed, evolute R26, right transfemoral route, safety wire from the contralateral side, balloon tip temporary pacemaker from the right IJV in view of right bundle branch block, because such patients would definitely are on a higher risk for permanent pacemaker post procedure. And if you have an IJV catheter with TPI, then probably early mobilization of the patient should not be a problem. Pigtail catheter from the right radial, because the left common iliac was critically diseased, and probably to do the procedure under local anesthesia, maybe with some sedation. Navigation of aortic arc in LAO view on a stiff wire, if needed, using rail, and be prepared to rotate the system after withdrawing it to the descending thoracic aorta. If it is not crossing, upgrade to stiffer wires, and maybe use buddy wires from the left side. So procedure, this is it. It was a balloon tip temporary pacemaker from the right IJV. And you could probably make out the calcium on both the aorto-iliac junction. I mean, it's a V, which you could easily see. And you could see that this is a regular wire, which sort of gets stuck at the lesion point. So this was probably to show the calcium and also to show the criticality of the left common iliac lesion. This was the right axis angiogram, which was done. And of course, this is not covering the lower part of the SFA, which would also show the occluded pseudoaneurysm. But I think for puncture, this was okay, and we didn't want it to give extra dye. And it was a USC guided puncture, but of course, I would always like to double check fluoroscopically to understand my puncture point in relation to the femoral head. And this is where we punctured with a micropuncture. And this is the sheath, which was a 14th sentence sheath. And also you can see the safety wire coming from the opposite side. It was a 018 B18 wire. And you could appreciate the amount of calcium in the iliacs as well as in the aorta on the right side also. There was a gritty sensation, but it was not a difficult passage, I would say. This is the pigtail catheter going down. And once we were happy, we placed it into the non-coronary sinus. And this first shoot was in the right coronary sinus because we wanted to take a coplanar view. And sometimes you would probably opacify all the three sinuses better if you put it in the right cusp for injections at least. And this is for the RL cusp overlay view. And now the pigtail is in the non-coronary sinus. This is regarding the checking of the valve, and it's loaded correctly. You could see the pedals and of course all the things that appear pretty straight. There's no curve. We used a Safari extra small wire because there was no horizontality, and it appeared that probably it should do the job, and it is of course our workhorse wire for TAVR. Used an 18 millimeter ZMET balloon because the minimum diameter was 18.5 or something, so probably -1 should be fine. We started probably somewhere keeping the marker at the middle of the pigtail, and then probably release slightly, double checked, and this was after reaching the 80%, and this was the right RAO caudal view, in which probably the depth on the non-coronary side was around 2 to 3, and this was the LAO cranial view. Of course, you could see that the right cusp appears too caudal in comparison to the non and the left, which is slightly unusual, because if you go cranial, typically the right cusp moves higher up, but I'm not sure why it behaved so. And then there was an angiogram. I would say that once the final release was done, we did an angiogram. And hemodynamics, you could see that there is some degree of mild PVL. Of course, the depth of the valve is around 3 in my mind, and there was some degree of PVL, and hemodynamics were good. So then we post-dilated with then 22 balloons straight away, because the perimeter derived was 22.4, and after that there was a very trivial PVL, and these were the final shoots. On the right side, you could see that there is the pseudoaneurysm has closed and the puncture point is pretty clean and neat. And also you could see that we just tried injecting, if we had done some damage, because there was some gritty feeling while going up, and there was hardly any damage done to the right common iliacs also. And result wise, there were no gradients on cath, good diastolic separation, good hemodynamics on cath, maybe around depth of 2 to 3 millimeters on the NCC side, trivial PVL on angiogram, on aortogram, mean systolic gradient of 4, and trivial PVL on 2D echo done on table. Transient complete heart block occurred few minutes post procedure, and the patient was underwent a dual chamber pacemaker next day morning and was discharged on day 3 post TAVR. Thanks.
Beautiful case. Beautiful case with so many points to touch that I will try to focus only on a few of them, because actually we can have a full session just touching on the various points raised by this extremely complicated case. First one is the right bundle branch. I'll start from the end. We know that there is a risk for right bundle. We know that for complete heart block following right bundle, especially if it comes with a trifascicular block, and you didn't mention whether the PR was prolonged or a left anterior hemiblock. And we should, I think, in right bundle, we should either consider preemptive, in some cases with trifascicular, putting a permanent pacemaker to begin with. Otherwise, we have the option of putting a screw-in lead. And then you know that you can watch the patient for 2-3 days before making a final decision. And I should mention that during the COVID days, in which we're trying to have, very short admissions, we had some cases in which on the initial admission for a patient, we put in a permanent pacemaker, did the procedure, and the day after the patient is home. Yeah. The additional point that I would like to raise is the vascular. In such a patient, my recommendation would be puncture with ultrasound, always, whether it's micropuncture or not. Ultrasound, directed, guided. It takes a little bit of time, to learn how to puncture, but then short, the procedure is shorter, less contrast. We're not injecting anymore from the contralateral at all. It's all ultrasound guided based on the CT scan. I know where I'm looking for puncture. And I learned that indeed, in your case, just the pressure obtained probe actually solved the issue of the pseudoaneurysm. We had a case a long time ago in which we had a pseudoaneurysm from the initial angio, and my decision at that time was go for the TAVI, and at the end put a covered stent to cover it all. I mean, we had a significant distance. and I decided to solve everything by covered stent, which is a viable option. But definitely your solution was safer. So I salute you for the wonderful case.
Thanks a lot. We did a USD guided puncture only, but the only thing is I would typically like to understand where is my needle hitting in relation to once you puncture, once I see the blood, I would immediately drop the probe and then put my foot on fluoro so that I understand the relationship of my needle with the femoral head. Because of course I am as cardiologists, we are good in understanding the anatomy, but sometimes you tend to puncture really very high with USG guidance, probably maybe because we are beginning to use this modality, but sometimes you tend to puncture really very high in thin patients. Maybe you are above the level of you are probably intra-abdominal. So just to be sure, I would always fluoro and check that whether I am really below or no, because I routinely start with the long axis to inject the local anesthesia, and then I will tilt the probe 90 degrees to come to the short axis and come to the middle point. But once or twice it has hit me really very high. Of course, the puncture was neat and I was safe, but I think that probably in just to be double sure, I will just do a fluoro to understand it.
I totally agree. Fluoro, but we're not injecting anymore. Fluoro, the head and neck of the head of the femur. You know from the CT scan where is the relation of the bifurcation, and unless it's a very high bifurcation, which I would advise maybe to inject as well. Otherwise, knowing where you put your probe, you can definitely and safely continue without injecting complex.
Yeah,
just ultrasound.
Yes.
Fantastic case, Manik sir. When you put it as a challenging access, I thought it's going to be a challenging access, but it's challenges all over from beginning to end. I think the most important thing is the planning. I think these cases, as you highlighted, every aspect has been planned perfectly. So you expect the worst and you plan for every aspect of it. And during the procedure, it all will go well. If you haven't anticipated that, and if you haven't planned it, then it will not happen. So it was a very, very well planned from starting from the access, and there is a kind of access for the pigtail and how you are going to position because of the right bundle. Every aspect is well planned and well executed. Now, optimizing femoral, obviously now the availability of IVL has made it much more convenient, especially for evolute. All we need is around sort of 4. Previously, we say 5 millimeters, even 4, or with calcification with 5. We are able to get away with just optimizing during the time of procedure with IVL. And I think Europe has got a lot of experience and we are starting to use it. Now, we are just about time for the next presentation. And I'll probably invite the other panelists to comment after Haim's presentation. So Haim Dannenberg obviously doesn't need introduction. As I said before, is the Director of Interventional Cardiology at the Hadash Hebrew University, Jerusalem. Is very well known in Europe as well as throughout the world. Extensive experience, more than 35 years, and extensive experience with proctoring for TAVR and other structural heart disease cases as well. And we are very, very happy and pleased to have you, Haim. And he's going to talk about how to perform valve fracture to prevent patient-process mismatch. In 2021 and 2022, this is very, very important. Now that we have got access to so many valves in India, I think this year, end of this year, we'll have access to at least 5 different valves, if not 6. And it's very important to give the patient the best. When they leave the table, they should go with less than 5 gradient and effective orifice area with no patient process mismatch. And that's what Haim will show us now. Thank you.
Thank you for the introduction. And I will actually continue the first speaker presentation, going on and discussing the issue of bioprosthetic valve fracture. We know that surgical aortic valve durability is dependent on age, with the risk of failure decreasing with increasing patient age. Durability may vary by valve model, with fewer than 10% of the patient over 25 will require more than this will require reprocedure. It's not operation anymore, but we know that those young patients will definitely require an additional procedure. We, as mentioned earlier, we indeed have both the stented and the stentless bioprosthesis, and most of the procedures that we do see are indeed those with the stented valves. We need to be familiar with each and every one of them. And we're learning more and more to differentiate with the different markers and the height of the sewing ring. Each valve is unique with its fluoroscopic appearance and with its characteristics. Part of them we'll touch in a short while. The ability to fracture or to remodel those valves. The valve failure is different in mechanism. Some of the patients would suffer from aortic stenosis, other from aortic insufficiency. You can see the different mechanisms by which the valve fails and reach either stenosis or insufficiency, whether it's spinous, thrombus, etc. Yet at the very end, in about 8 to 10 years, and this is based on the VIVID registry, we'll see the peak of valve degeneration that will call for an repeated procedure. Now, every valve that we're familiar with was actually used in some numbers to TAV in SAV, valve in valve, but as Dr. Gupta so nicely illustrated, I think that currently the valve of choice, especially in small valve, is the supraannular valve. Bini Bapat provided us with an excellent app, and I would advise each and every one of you who's performing valve in valve procedure to have this on your mobile phone and learn so much on the characteristic and which valve is the valve of choice in valve failure. Now, it's a very effective procedure. Valve in valve, by all means, is a wonderful procedure, reducing gradients, improving insufficiency in those cases of insufficiency, improving the quality of life as judged by the NIHA class. No questions asked. It's a wonderful procedure. We know that patients with valve stenosis, surgical valve stenosis, are more prone, are more complex, and will have higher mortality. The consequences, the long-term results will be worse than those that suffer from insufficiency, and moreover, as smaller is the surgical valve, the outcome is worse. Smaller valves tend to have a worse outcome. We need to be definitely more careful regarding these patients. As you can see here, patients with a valve equal to or smaller than 21 millimeter in diameter, and this is the outer ring, not the inner diameter. Well, these patients are at a worse outcome. And the Achilles heel of valve in valve procedure is the residual stenosis. And we know this this happens definitely in the smaller valves. You can see here, down here, and these are all results of the valve in valve registry, the VIVID registry conducted by Danny Dvir and then Uri Landes, my colleague from Wolfson Hospital nowadays. These guys are running the registry so nicely now. And you see here, smaller valves tend to have higher rates of post-procedure mean gradients that are associated with the worst outcome. And we can see here, definitely more with the balloon expandable in smaller valves, higher gradients with balloon expandable as compared to the self-expandable Evolut platform. High gradients are associated with patient prosthesis mismatch. It's very easy nowadays actually to calculate, to know the potential risk for patient prosthesis mismatch beforehand based on the body surface area. And there are those tables at disposal that can give you the data on the potential risk for patient prosthesis mismatch. Smaller valves, higher gradients are associated with a higher risk for severe patient prosthesis mismatch, and this is associated with higher mortality. Patient prosthesis mismatch, higher mortality, and we know native valves have an area of 3 to 4 centimeters. patients will not experience symptoms of aortic stenosis until the area is definitely less than half or more than that. A large effective orifice area will lead, as possible, the largest possible, will limit the amount of residual stenosis, will allow returning much faster to activity. A Cleveland Clinic study of more than 3,000 patients illustrated that younger patients were less tolerant, and this is a major point, less tolerant to patient prosthesis mismatches. They were more likely to become more active, and therefore we should definitely address this, try to reduce the risk for patient prosthesis mismatch. And we know that this happens in smaller valve. Now, I would like to show one case in which we consider patient prosthesis mismatch and ended up without, and then with your permission, touch on the point of balloon fracture. Here is a 76-year-old female that had a Magna 19 8 years ago, short of breath, severe aortic stenosis, mean gradient of 75 millimeters of mercury. As you can see here, the true ID of the Magna 19 is 70 millimeters of mercury. And here we had another concern, not only of patient prosthesis mismatch, but of coronary occlusion. She had an ostial right coronary lesion that was treated prior to TAVI with a single stent, and the lower origin of the left main, as you can see here, very small diameters and very low origin of the left main, 4.6 millimeters, as you can see here. Fortunately, there was enough distance, and I'm showing here, of course, the self-expandable evolute. It is a 23 evolute. No, and as you can see here, I'm using a Landequist. Even in this quite vertical valve, I'm trying to improve my stability and coaxiality. And take a look, you can see here, and guiding catheter. We're protecting the left main. Here is a stent, a 3.5 stent that is parked in the middle of the LAD. We're protecting the left main, ready for a chimney. And we're injecting again and again at the point of no return, both from the coronary guiding catheter as well as supraortic injection to be sure that we've got enough space. And yet, before final release, we're not taking out the, we're not taking out the guiding catheter. And you can see here, we're still parked at the LAD. And only now, after verifying, you see the guiding catheter, verifying that coronary flow is fine, we're withdrawing, and you can see here, this is fluoro. I'll show this slowly how this is done. Going without trying to bring the stent to the guiding, but kind of pulling it all together, taking out the wire, stent, and the guiding catheter. Fortunately here, the gradient was 2 millimeters of mercury, no need in any additional measure. We're ready to post-dilate. But then, in some cases, we need to fracture the valve. And then we're taking a non-compliant balloon, a true balloon or an Atlas Gold, 1 millimeter larger than the internal diameter of the surgical valve, inflate until either we see a sudden drop in pressure, an audible snap, or a visual fracture of the ring. And usually we're trying to see all three. So let me show you how this is done. Here is a 68-year-old gentleman, as you can see here, quite overweight, morbidly obese, with a large body surface area. 9 years before procedure, he had a SAVR, surgical aortic valve replacement, with a Mosaic 21, with a residual gradient at that time of 40 millimeters of mercury. He didn't do that well, but since he's not very active, he had a almost normal quality of life, up to a point in which he had a endocarditis, ended up with severe AI, And at this point, he needed therapy. So here we didn't even consider whether we put in a valve and then consider a fracture. But then prior to procedure, we used a 22 balloon, as you can see here, inflated up to a point that it fractured the ring. This is a mosaic, so the surgical ring is much lower, ended up 4 millimeters gradient. And here is, and this is kind of more illustrative case, 87-year-old gentleman with a perimount, again, a perimount 21, 15 years ago. Severe surgical valve deterioration, mean gradient of 60 millimeters of mercury, functional capacity 3, admitted for pulmonary edema. We definitely had to treat. And here, since he didn't have patient prosthesis mismatch to begin with, we tried putting in the valve prior to, we had the option for valve fracture, but didn't do it prior to valve deployment. You can see here the exact measurements. As we can see here, there is a decent distance to the left main, so no major concern of coronary obstruction. The valve to coronary is 7.4 and 6.1 for the right. Very favorable numbers. As you can see here, the femorals are quite nice. And take a look. After the procedure, we ended up with a gradient of 30 millimeters gradient. So using a true balloon, 20. The internal diameter is 19, so a 20 millimeter true balloon. And take a look here at this point. I hope you could see here, we even heard the snap and we looked for the fracture, and here is the fracture in the ring. You can see a nice fracture in the ring. The gradient disappeared. No gradient at this point, the 23 in perimount, no gradient. Patient was discharged a day after procedure, no conduction defects. And up to 3 months follow-up is doing very, very well. So just to conclude, bioprosthetic valve fracture is a very successful and a very effective procedure and quite safe as well. As you can see here, reducing gradients. And these are the sentinel works of Keith Allen from Kansas City, and increasing the mean valve effective orifice area quite nicely. There are some valves that cannot be fractured, and these are the trifecta and the Hancock valves. Other than these, all the other mosaic, mitral flow, magna, perimount are, I wouldn't say easily, but can definitely be fractured. Again, using a non-compliant either Atlas Gold or balloon. Now there are some considerations to favor either before or after valve deployment. When you do it before, no high pressure, even potential damage to the valve leaflets, to the transcatheter aortic valve leaflets. When you do it after, the decision is made only after measurements of gradients, and we can maybe skip some procedures that are unnecessary, and we add the optimal expansion of the transcatheter aortic valve. There is a very nice series of balloon valve fracture versus no balloon valve fracture that was presented in the last TCT by Brinkman. It's a large series of 160 cases comparing 80 to 80. And actually, if I'd like to conclude this one, you see here that a very various variable population of patients, stenosis, regurgitation, mixed procedure with moderate to severe PPM in a large number of them, more of course in those balloon valve fracture. As you can see here, all kinds of valves were fractured, including those that cannot be fractured, but potentially remodeled, just the ring somewhat enlarged. And as you can see here, gradients are definitely lower in those in which the valve was fractured. The predictors for low gradients are balloon valve fracture, self-expandable valve, of course, the supraannularity of the evolute, and the worst valve to treat, the mitral flow. So whenever it's not a mitral flow, the results are definitely more favorable. As you can see here, not that many severe complications other than 2 cases of VSD. We haven't seen much, and it appears that it's even safer than those patients that were not treated with balloon valve fracture. So in conclusion, TAVI therapy for degenerated surgical aortic valve is expanding. Post-procedural gradients and patient prosthesis mismatch are associated with worse outcomes, and BVF, bioprosthetic valve fracture, is safe and effective in reducing patient prosthesis mismatch and improving outcome. And I'd like to conclude with one of my favorite quotes, the one of JFK, which I repeat again and again. There are risks and costs to action, but they are far less than the long-range risk of comfortable inaction, like not doing a procedure. Thank you very much.
It is fantastic, Haim. Fantastic presentation with great concluding words from JFK, I think, which aptly fits for this. Now, Sridhar sir has joined, and he can probably start in terms of the discussion, and then the other panelists will get involved. And in the end, you can just mention a few words on the leaflets placed outside and the newer technique that's coming up, the shortcut which is coming from Israel. You can mention in the end. Sridhar sir?
Yeah, good evening. Thank you, all of you, for joining this webinar. I request all of you to apologize me for joining late because of I stuck with one complex PCA where we did the rota tripsy. So because that joined very late. Anyhow, I express my apologies once again. Sir, thank you very much, Dr. Haim Denenberg, for joining, and very nice presentation, many teaching points. Sir, my doubt, when you are upsizing, suppose it's even with 1 ml volume increasing, you are not fracturing, what would be the next step? Are you going to increase the 2 ml or will you accept like that? Another one, how often do you see the annular rupture with high pressure inflation?
As can be seen by the both the papers by Allen and by Brinkman, very few. Annular rupture, especially, you've got a ring already that is protecting the annulus, so the risk is very, very low. When you do this for the first time, let's be honest, it's quite scary, but then you realize that when you do it in a controlled manner, you're not taking a very large balloon, but 1 millimeter larger than the inner diameter, and you go slowly with the indiflator. We go more and more slowly, adding contrast. I've done, as you can understand, quite a few number of cases. It appears as a very safe procedure. And it's surprising to see how the gradients all of a sudden drop from 30, we had a case of 40 millimeters gradient, all of a sudden single digit to none. So slowly using the right equipment, I think it's a very safe procedure. Definitely when you've got both the self-expandable inside a ring, then I think that here it's even safer than doing this prior to valve deployment.
Just one more thing I wanted to ask. 2-3 questions. One, when you're anticipating valve-in-valve fracture, would you do it under local anesthesia or do you do it on general anesthesia? Because I feel that the duration of time which you take for inflation and deflation in valve fracture would be definitely probably 10-15 seconds or so. Second thing is, what is your threshold? Is it the true ID +1, or is it the stent ID +1, or is it the valve size +1? What is your take for valve fracture? And third thing is, for example, if there are gradients of like 10 or maybe a peak to peak gradient of 10 or 12, how do you decide whether you want to post-dilate or whether you want to fracture?
All very good questions. So I'll touch one by one. First, regarding the anesthesia, and there was a question on the chat. What's my advice for anesthesia? I'm doing 95 to 99% of my cases under local with sedation. And I enjoy the comfort of having an anesthesiologist with me. Will provide the patient with sedation that can vary from mild to deep sedation according to the patient will. In these procedures, I will do it under sedation as well, but maybe kind of a deeper sedation. I wouldn't like the patient to move. It definitely takes 10 to 15 seconds. The inflation is gradual. You're not going, as you can see, and I wanted you to see the actual clip of how this is done. I think that sedation can be, is definitely enough. Now, you asked regarding kind of a borderline gradient. If it's 8 to 10 millimeters of mercury, I would probably skip the, I wouldn't perform a BVF. It's not a procedure that should be done in any case, but if it's higher than the, it's in the 2-digit range, I would go for a BVF. There is another point here. If it's an 89-year-old patient, maybe I would 10 to 12 millimeters of mercury can be definitely taking. I mean, you don't need an additional procedure. When it's done in a 70-year-old, 65-year-old, I would try to come up with an excellent result and no gradient at all. There was another question.
Yeah, what is your threshold? What is the size of balloon? Is it true ID +1 or is it the stent?
True ID +1. And there was a case in which we needed to go up to the true, that a 20 wasn't good enough and the 22 did the job.
Okay, for example.
No more than that. I wouldn't use any more than that. If it wouldn't fracture, I haven't seen cases in which it didn't fracture, but I wouldn't go any higher than that.
So for example, if we take, for example, let's take EPIC 21. Now, EPIC 21 internal ID is 17. So would you go with the 18 balloon to fracture?
Yep, I would go with an 18, but remember, this is a non-compliant. It's not the regular balloon. This is either an Atlas Gold or the true balloon. I would go with an 18. Maybe I would have on the shelf a 20, but I would hope that the 18 would provide me with the.
Okay, my only concern is if we go with 20, probably we are just doing for once. For example, if it doesn't happen with 18, then you have to do it with 20, and it would probably damage the leaflets more, or I'm not sure.
No, the 20 wouldn't damage the leaflet of the valve, would stay as the same because they can definitely take a 20. The potential risk is indeed to the annulus, and therefore 18 and 20 can be easily used as well. But once I'm doing an 18, even if it didn't fracture, I wouldn't run immediately for 20. I would first measure the gradient. If the gradient, if I haven't fractured but just brought the valve to a better coaptation with the ring, I'm done with that.
And would you try 22 by any chance in this?
No, I would not take a 22 for a 21 valve. That's
yeah, because the waste for this 23 ER, which we are going to put, also is 20, and definitely there would be a higher chance of damage to the THV valve leaflets because this Medtronic Evolute R would have a waste of 20, and going with the 22 balloon would definitely probably damage that also. But if I'm correct, the benchmark studies were done with 1+ of the stent valve size. Am I?
Yeah.
Okay. All right. Many thanks. Many thanks. Have you used Vida balloon by any chance?
Which one?
Vida balloon.
No, not familiar with it.
It's from Bard only, but its make and everything is just like Atlas Gold. So the rated burst pressure, everything is just the same. The only thing is
the so far both the true balloon and the Atlas Gold provide. You could see immediately the difference between these balloons and the semi-compliant. You could see the almost like what we're familiar with the coronary, the difference between a non-compliant to a semi-compliant.
This Vida balloon is almost the it is probably the company is going to replace Atlas Gold with Vida, because Atlas Gold now availability in India is slightly difficult. I mean, we do get we don't have BARD, we don't have True Balloon, and the only balloon which we have is Atlas Gold, and that also the availability is getting scarce and scarce. The other balloon which is sort of replacing Atlas Gold is Vida balloon, which is again from BARD. It has got the same configuration for rated burst pressure. The only thing is it inflates and deflates slightly faster. So probably
even better, just goes in our side. I would definitely use it.
Okay. Thanks for the help.
Any comments from Dr. Rahul and Dr. Shivakumar sir? Dr. Rahul?
Yeah, so the only question is how high is the pressure? Is the hand pressure which we try to inflate the balloon, or we use the inflation device and decide the pressure when we are?
I'm using an inflator, an inflation device. We're going 8, 10 atmospheres, and in this range, usually we do see the bursting. But what we're doing is we're going very slow, and as I showed in the slide, we're connecting kind of a syringe to provide us with enough contrast, and we go slowly, one by one, from 6, 7, 8. Usually by 10 atmospheres, you see the fracture. You hear the fracture.
Thank you.
It's surprising to hear the snap. You hear an audible snap.
If there are no further questions, I would like to request Dr. Anantaraman to speak on TAVR with ICE and MICRA case examples. Over to you, Dr. Anantaraman.
Can you see my slides?
Yeah.
Okay. Now, obviously, I'll just show the first presentation on TAVI with MICRA. It's a perfect harmony in severe aortic stenosis with heart blocks, symptomatic heart block. And we'll be discussing this first case in India, which was done at Sunshine Hospital with Dr. Kasturi sir and team and myself. It's an appropriate patient as well, 77-year-old, hypertensive, diabetic, and sleep apnea, very high BMI. Weight was between 105 to 110 kgs and 35 BMI. Patient already had a right bundle and as well as Holter showing intermittent complete heart block. An echo confirmed severe aortic stenosis and severe pulmonary hypertension, valve area of 0.9, aortic valve area, and pressure gradients of 150, and systolic or systolic pressure around 50 plus. Other laboratory parameters were satisfactory. Hemoglobin 14 and other parameters were satisfactory. BNP was slightly high. So we had a detailed discussion. Obviously, there was a severe aortic stenosis, and the score was on the moderate score, moderate to high score for surgical AVR. So decided for TAVI after the heart team discussion. Then, along with the team at Sunshine, I discussed, and we felt that for various reasons, if affordability is not an issue, the perfect solution for this will be to put the TAVI and also put a MICRA AV at the same time, rather than waiting to see, because the ECG on that day showed right bundle, but not sort of complete heart block, but Holter previously confirmed the complete heart block. So we agreed on consensus that we will do a pacemaker, but affordability was not issue, and also because of the high BMI and all the other associated issues with the high BMI patients for a pacemaker, we opted to do the TAVI with MICRA for this patient. So that was the ECG that day, but before that, the Holter has confirmed intermittent complete heart block as well. So this is echo showing a calcified aortic valve, severe aortic stenosis, and the gradients almost 5 meters per second. Coronaries were reasonably good, apart from mild atheromatous disease. And the CT assessment showed it was on the cusp of you can use a 26 or a 29. The perimeter was 72.3, and the area was 405. So we opted to use a 26 here. All the other parameters, the sinus was more than 30, Coronary heights were very good. So ascending aorta was 35. So all the other parameters were reasonably good. The reason to choose 26 rather than 29 was the LVOT was slightly smaller than the annulus. So I opted for the 26. Yeah. Femorals were pretty good, more than 6.5 to 7. So you could easily put a 18 and do all the procedure and then remove the 18 French sheath. So this is what I was saying, 72.3. It's exactly on the cusp for a 26 to 29. So you have to decide based on the other factors, as I mentioned, LVOT, calcium, annular calcium, leaflet calcium, all the other factors. And we opted for 26 because of the LVOT size. These are the two valves that's available. And here we selected the self-expandable for various reasons. The micra is like this. Micra will be implanted in the heart itself, in the RV. Now we have the AV micra, so that more than 95% chance of getting synchrony. So the TPA was placed first. Following that, aortogram and the non-coronary sinus, routine procedure. There's some issue with the
Otherwise, go to next slide and see. Not moving.
I think Dr. Rajaram's this thing is net as
Yes,
folder is
sir.
also still.
I think we lost Dr. Rajaram. So Dr. Rajaram got disconnected.
Then we will move on to the next topic. Then Anantaraman can join later. Dr. Shivakumar garu, are you ready?
Yes, Dr. Kasturi.
Very good evening, sir. Nice to see you after a long time. I think if you are ready, you can go ahead. Everybody knows Dr. Shivakumar is very well known and one of the pioneer in congenital intervention, all complex interventional procedures. He's a very good teacher. And we are very happy to listen to you. We are very eager and keen to listen to you. Over to you, Dr. Shivakumar.
Thank you, Dr. Kasturi, for inviting us amidst all the experts on aortic valve, giving a small piece of cake for the pulmonary as well. What are the basic subsets of the patients? Unlike many of the aortic valve whom you are talking about, who are quite in the elderly age group, having multiple comorbidities that includes coronary artery disease, the subset of patients who need percutaneous pulmonary valve implantations are broadly into three groups. Number one is those who have the native right ventricular outflow tract that has been repaired as a part of their congenital heart procedure, like tetralogy of Fallot or pulmonary valvotomy, surgical pulmonary valvotomy, or some of the surgical procedures like REV procedure. Yeah, a good number of them will be use of conduits, either homograft conduits or xenograft conduits in procedures like Rastelli repair, which is done for transpositions, Ross procedure that is done as an alternative for aortic valve mechanical or bioprosthetic valve replacement in a small patient, and truncus arteriosus repair. The third one will be the use of bioprosthetic valves in the past for a repair of the right ventricular outflow tract. So these will be the three broad subsets of the patients. What is the natural history when these patients are continued to follow? The conduits and bioprosthetic valves, they degenerate and they become stenotic. When they become stenotic, the pulmonary stenosis increases the right ventricular systolic pressure, right ventricle fails, secondary tricuspid regurgitation sets in, and they go into right heart failure. The Other group, the native right ventricular outflow tract repair, where there is a pulmonary regurgitation. The pulmonary regurgitation progressively keeps increasing over a period of time. This results in RV dilatation and RV dysfunction, and later QRS widening with electrical and mechanical dyssynchrony. So when is pulmonary valve indicated in this group of patients with pulmonary stenosis and pulmonary regurgitation? So now the new AHA recommendations, they grade a patient with valve disease as stage A, B, C, D, of which stage D is symptomatic heart failure. So any patient who is having pulmonary stenosis with symptomatic heart failure, they need pulmonary valve implantation. Suppose let us assume that the patient is asymptomatic, that means stage C2, but associated RV dysfunction, then again they will need pulmonary valve replacement, because the pulmonary stenosis is going to be hurting this patient more and more. What is defined as RV dysfunction for the purpose of defining the stage C2 is RV ejection fraction less than 47% on cardiac MRI. Then what comes to the stage C1 patients who are asymptomatic, who have preserved RV function? If these patients, if the RV pressure is more than 2/3 systemic, or if the RVOT gradient is more than 50, these patients will tend to progress soon into from stage C1 into either stage C2 or to stage D, and hence they warrant intervention. So this is in the pulmonary stenosis group. Now coming to this pink slide, this is stage D with symptomatic pulmonary regurgitation with heart failure. They are straightaway indicators for PPVA. Stage C2, if there is a severe PR, the definition of severe PR is pulmonary regurgitation fraction on cardiac MRI more than 30%. In these patients, if they have RV dysfunction. So RV dysfunction is, as already mentioned, less than 47. There is also an additional category called LV ejection fraction less than 55. The reason is, as the RV keeps dilating more and more, it tends to cause a diastolic flattening of the interventricular septum, thereby reducing the left ventricular filling, and the left ventricular ejection fraction also goes down. So either an RVEF less than 47 or LVEF less than 55, they become stage C2. Stage C1 is those who are having severe PR as defined by pulmonary regurgitation fraction more than 30, those who are asymptomatic, but they are having large sized RV, which means end diastolic volume indexed more than 160, end systolic volume indexed more than 80, RV to LV volume ratio more than 2, or a QRS duration of more than 180 milliseconds with or without associated ventricular arrhythmias. So this will be the indications for considering for a percutaneous pulmonary valve, because these patients already would have had few heart surgeries in the past, and so surgery becomes higher risk even at a relatively earlier age. So as I mentioned earlier, the three anatomical subsets: degenerated conduits, where Melody valve serves as a very good alternative; degenerated bioprosthetic valves, again Melody valve serves as a good alternative; native right ventricular outflow tract. In a good number of patients, native right ventricular outflow tracts will be there, which means 70% of the patients do not have conduits or bioprosthetic valves. In these patients, we consider Melody if the RVOT is less than 22 millimeter, Sapien S3 if the RVOT is less than 26 millimeter, and My valve if the RVOT is less than 29 millimeters. So by and large, when we talk about a percutaneous pulmonary valve with a Melody valve, it confines to either a degenerated conduit or a degenerated bioprosthesis. I'll start with a simple example. A 30-year-old lady with an original diagnosis of TOF with absent pulmonary valve syndrome operated at 10 years of age with a conduit repair using a 22 millimeter homograft. This patient develops progressive conduit valve degeneration with combination of stenosis, gradient of 40, with severe pulmonary regurgitation, symptomatic worsening to class 3, right ventricular end diastolic volume indexed going 190 ml, so volume is becoming too high. Ejection fraction is 44, so RV dysfunction is sitting, and there is severe pulmonary regurgitation because the pulmonary regurgitation fraction is 45% on cardiac MRI. So because of the presence of symptoms, this patient actually will come to stage D indication for a pulmonary valve implantation. So This is the pulmonary lateral view angiogram. You can see the pigtail rocking up and down due to the severe pulmonary regurgitation with the combination of 40 millimeters of mercury gradient. A balloon interrogation is a standard practice because the coronaries may be compressed in about 3 to 5% of patients as we are dilating and stenting the right ventricular outflow tract. So always the coronaries needs to be checked with the balloon occlusion. So this is a balloon interrogation of the coronary, which shows that the coronary is too far away. And then this is a single stage implantation, a 22 ensemble system, which is the delivery system, where the melody valve is mounted. And then surrounding the melody valve, we put an andra stent because there is a tendency for the melody valve to fracture in a right ventricular outflow tract. I'll show it on the lateral view. You can see that there is a melody valve here, the black one, but surrounding it, you can see that we have put in an andra stent. So this andra stent is like a pre-stent plus the melody valve combined as a one-step strategy. So both are inflated, the melody valve has been deployed, coronary is checked, the coronary is far away. You can see the full andra stent outside the melody valve. And so the procedure has been completed with no pulmonary regurgitation. This is the pulmonary artery angiogram in lateral view and in AP view, both showing good functioning pulmonary valve. How it is very simple, a stenosed conduit, there is no pre-stenting that was done because melody valve allows stenting along with the valve in one shot as a single step strategy. It has a very short procedural time. Rewarding hemodynamics, final RVOT gradient was less than 10 with no PR, with a follow-up of more than 4 years on dual antiplatelets, aspirin and Plavix. The other group where this is similarly very simple is a degenerated tissue valve. This is a perimount valve. A perimount valve in position. This is a 25 millimeter perimount valve, which coronaries are being checked. The chances of coronary compression during a valve-in-valve implantation is extremely unlikely because we may not be fracturing these valves unless these valves are highly stenotic. As it was mentioned by the two previous speakers, in pulmonary position, we tend to go up to +2 millimeter for a bioprosthetic valve if at all we need to fracture. Now, this is the ballooning that has been done with an Atlas Gold. This is just to test whether the valve can be fully expanded. Cracking is possible in certain types of bioprosthetic valve, which was already discussed. However, in a 25 millimeter perimount valve, we don't want to fracture it because the melody valve needs to be only 22 millimeters. So this is a melody valve that is going up, and the final valve-in-valve position, the valve is fully competent, both on the AP projection as well as in the lateral projection. You can appreciate that the valve is functioning. These are the two groups of patients where the melody valve implantation is very simple. Now I'll slowly introduce complexity to the procedure. The first complexity is if there is an associated branch pulmonary artery stenosis. You can appreciate here, there is an associated LPA origin stenosis. We have positioned a stent in the LPA origin here, and which is being expanded. Once the LPA stent has been expanded, then you do the balloon sizing of the conduit. So this is the LPA stent in place. You are balloon sizing the conduit and the coronaries are normal. The next step will be implanting the melody valve. This is the pre-stenting. The pre-stenting is done with the CP stent. This is the LPA stent and this is the conduit stent. And once the pre-stenting is performed, the melody goes within the pre-stent. The melody valve is getting deployed with coronary checks, and the final angiogram shows that the valve is nicely competent both on AP as well as lateral projection. So the first complexity was a coexistent pulmonary artery branch stenosis, because we first address the branch pulmonary artery stenosis and then come for the valve. The second complexity is the risk of coronary compression. A 50-year-old person who had a Ross procedure where the pulmonary valve was taken and used as the aortic valve, and the pulmonary valve was replaced with the homograft conduit. This patient develops progressive stenosis. You can appreciate the Ross pulmonary conduit having circumferential near circumferential. I would say rather 320 degree of circumference, 310 degree of circumferential calcification with a small gap here. So the risk factors here are when we are fracturing this calcium, the calcium may tend to go posteriorly and may sometimes press on these two coronary arteries. So this is the right coronary and this is the left coronary artery, and it may be pressing. So if we imagine that this is going to be the post-dilated conduit, it may tend to compress the LC or RCA. And so in these patients, we need to do a proper balloon testing. So this is a 16 millimeter balloon that is being inflated. You can appreciate we have a catheter that is positioned in the left coronary artery with the coronary guide wire that is going through. This is in order to retain the stability of the guide catheter within the left coronary artery ostia. Similarly, you can see that there is a right coronary which is again having a coronary guide and that is engaged. RCA is also not occluded at 16 millimeter. Then we go for the next balloon, 20 millimeter. You can appreciate the LCA is flowing well, the RCA is flowing well. So that means 20 millimeter, this patient is not getting into any trouble. So it is fit enough for a melody valve implantation. However, when we want to try a 22 millimeter, we can appreciate here carefully in this position that the LMCA is getting squeezed by the large 22 millimeter balloon. So this patient is going to be unsafe for a 22 millimeter melody valve, but is acceptable for a 20 millimeter melody valve. And hence, with this knowledge, we put in a 20 millimeter melody valve already with the, as I mentioned earlier, with the pre-stent that has been deployed as a one-step procedure. So there is an Andra stent around the melody valve. And here you can appreciate that the valve is perfectly functioning. It's a 20 millimeter melody valve. We still continue to have the left coronary artery wired here. Now we do a coronary checking, and the coronary is flowing without any problem. Here again, the coronary is flowing on a caudal projection without any obstruction. So the first complexity that we saw was branch pulmonary artery narrowing. The second complexity is a potential coronary compression, how we are getting out. The third complexity is multiplicity of the previous procedure. This was a failed Ross. AVR was done. After the AVR, there was an ascending aortic dilatation. Bental was done. Multiple surgeries, and now the patient needs a conduit, RV to PA conduit to be changed. So this patient, this is the RV to PA conduit, and this is the pre-stenting that has been done with a CP stent. The coronaries are not getting compressed, and then you put in the melody valve. The melody valve is functioning pretty well, and there is no pulmonary regurgitation. The last part of complexity will be in relatively younger children. This is a small child who is 10-year-old, who has had 4 surgeries in the past, and this is one of the conduit with severe stenosis. And this stenosis, now we are going ahead with the balloon testing. So on a balloon testing, we can appreciate that the coronaries are not getting compressed. The child is just 25 kilogram, and this is the 22 millimeter melody valve that has been deployed. Again, as one-step strategy, you can appreciate the Andra stent and the melody valve together. And once the stent has been, the melody valve has been deployed, there is no pulmonary regurgitation. There is a complete relief of RVOT gradient. So to summarize, melody valve and the other percutaneous valves has avoided many redo surgeries in most forms of heart diseases that involve repair of the right ventricular outflow tract. The simple ones are stenotic non-calcified conduits, as I showed in the first patient, or bioprosthetic valves. Increasing complexity will come in with branch pulmonary artery stenosis, patients at risk of coronary compression, patients having circumferentially calcified conduits, patients who had multiple redo surgeries in the past, and relatively smaller children. The only advantage of a melody valve is that it is technically a simple implantation that does not need too much of technicians for even valve mounting. It is a doctor mounted valve, and hence this is the prime advantage of this particular valve. Thanks a lot for the opportunity given.
Yeah, wonderful presentation. You narrated step by step, particularly how to look for the coronary compression, balloon upsizing. That is how to avoid the complications like a sudden coronary occlusions. And wonderful image. Really, you showed me a beautiful images, and every step meticulously is shown. I take Hearty congratulations. Thank you for obliging our invitation. It's a very educational lecture. Thank you. Over to Anantaraman.
Yes, Shiva, I know him very well. We have worked in many cases together. And as far as the pulmonary valve implantation is concerned, he's got the most experience in India as well as in Asia, both Melody as well as all the other valves, including the venous P valves. So it's a pleasure to have Shiva, and the presentation is always from basics up to the most difficult cases you can see, because he's got the experience with them all. Now, one question to you, Shiva, is obviously one of the major aspects for the Melody is the cooptation, because it is the natural available jugular vein with a high depth of cooptation. And when you're putting in younger patients like 14, 15-year-old, the advantage is you can keep dilating maybe once a year, twice, or whenever it is needed, and still you will keep the cooptation, which is not there with the other available valves. What's your take on that, and especially in the younger patients?
Yeah, it's true. But while the point that you are mentioning is extremely vital, especially in very small children where a Melody valve is used as a surgical mitral valve. Let's assume you have a child who is 1 year or 2 year who is getting a complex dysplastic mitral valve, and you have to repair that mitral valve and you fail a repair. And then you are forced to surgically take a Melody valve and stitch it in the mitral position. There, very often the valve, the annulus will allow only about 13 millimeter or 12 millimeter. So you just under deploy a Melody valve to only 12 or 13 millimeter when the child is hardly about 8 or 9 kilogram. And then when the child reaches about 3 years or 5 years, then you go do a septal puncture and progressively keep on dilating this valve. Fortunately, this valve will allow a dilatation up to 18 to 20 or even 22 millimeters. So that is the place where this serial dilatation works. While when we talk about pulmonary, it's most of the time we try to reach the target on the day of deployment, which means we try to get it as high as possible. The basic principle of whatever you have been talking all along, I was hearing when people were putting in the 19 and 21 millimeter aortic valve and try to get the best orifice area. The same logic comes for pulmonary, because it's the same cardiac output that goes through the pulmonary valve as well. So you try to get the maximum size. So since Melody is available as 22, very often we try to hit 22. If at all 20, never less than 20. So in pulmonary, a serial dilatation is not a very key factor, but in mitral, it is a very important factor.
The second thing is the endocarditis seems to be higher in the pulmonary transcatheter compared to the aortic or mitrals we are doing. The endocarditis is much higher. It is reported, it's well known.
Exactly.
Just a couple of comments on that.
Yeah. The average annual incidence of infective endocarditis after a pulmonary valve implantation, especially with Melody, is somewhere hovering around 2% per year, which is extremely high, especially since it is a relatively younger population and you need to have a very long longitudinal follow-up of these patients. So this is of significant concern. One of the basic problem about this entire technology is that we are trying to put in a valve on a degenerated dead tissue, which means a previous pulmonary homograft or a previous xenograft. And within a dead tissue, now you are trying to stretch open a valve, which is completely unlike your TAVI procedures that you are doing routinely, where the surrounding tissues are viable. The surrounding tissue has vitality. Here, this is a non-vital area where we are putting in an implant and we are stretching it. And hence, non-vital tissues tends to have a better harbor of varieties of organisms. So as a protocol, these patients are given education for at least about a week prior to the procedure. They get all their dental problems sorted out. They are strictly told no tattoos, follow a very healthy lifestyle, decent, a very, very disciplined lifestyle in the future, and try to hit at any episode of fever with a very early cultures, identifying the agent and treating them very aggressively, so that we try to protect the valve as best as possible. Yeah, close to about 75% of the Melody valve endocarditis have been managed conservatively, which means if you are picking them up earlier and giving them the usual appropriate antibiotics, they tend to work. So yeah, it is of concern. The concern is because of the non-vital tissues getting in a valve, contrary to an evolutor or a Sapien S3 on a native aortic valve tissue, where vitality is not a question at all.
Yeah, thank you. Before I complete my presentation, I asked, Haim is there? Haim?
Sir, you have to unmute, Dr. Denenberg. Sir, you have to unmute.
Sorry, guys.
No, that's okay.
It was a wonderful presentation, very didactic, and I need to be honest, I'm not that familiar. I'm blessed to work with pediatric interventional cardiologists that are doing all the pulmonary procedure. I was especially impressed by the combined pre-stenting. I knew that it calls for pre-stenting altogether. Very impressive. Honestly, I've got not much to contribute to this wonderful presentation.
Any comments from any other panelists before I start and complete my presentation?
I think you can go ahead, Dr.
Okay. Apologies for the glitch. The laptop suddenly crashed. Can you see the video?
Yeah, playing well.
Okay, I'll just make it quick, 10 minutes. This is a standard procedure. So pacing wire is there, pigtail is there, aortogram is done, and we get both the planes, the cuspal overlap view as well as the coplanar view on the right side. But majority of the self-expanding implant is done with the cuspal overlap view in this one, where the non-coronary is on the lowest point. And then confirmation is done with the coplanar view. That is the standard practice for the self-expanding valve. So the valve was crossed by Sridhar sir very eloquently within a sort of 2-3 minutes. And after that, this is the ballooning standard again. An 18 balloon was used with pacing, 14 and then 18. And this is the cuspal overlap view. We wanted to have almost a 0 to 1 implant here. It's a bicuspid valve. And that's exactly what was achieved. Almost a 0 implant, as you can see, 2/3 implanted and then checked. And once we satisfied, we release the valve. The controlled pacing, I keep it for 5 minutes after deployment. Nowadays, that is a practice which I have adapted, and it's about 1 millimeter depth. And following that, the Micra, as I said, it's a standard procedure, and now it's becoming more readily available in India. The major advantage is, especially in this obese patient, as well as where the infection risk is high, lead displacement will be a major problem. This eliminates all the pocket-related issues. Cost is an issue. It's almost twice the cost as a normal pacemaker. Otherwise, it is the choice in terms of pacing, especially if you have had already intermittent complete heart block. So it's again a catheter technique. So right femoral vein and the sheath, and you take it into the RV, and you are into the septum. You want it to be between mid and lower septum. You don't want it to be too low, so around mid septum. And you confirm it with the sheath angiogram. You are in the septum. And then you release it, and you assess the stability by the pull, and you can see the prongs. At least 3 of them should be holding it, minimum 3. After that, you retrieve the sheath, and everything is done and dusted, so that you just close the femoral access and you leave the patient with the TAVI and the Micra device. So that was the perfect harmony in these patients where there is heart block as well as severe aortic stenosis, and both the procedures done together. And the sheath is closed with 1 ProGlide, and that is the post. Now the other sort of important development is, I'll just show 4 or 5 slides, and that's it. It should be fine. Is in patients who we want to do conscious sedation, but for various reasons it is difficult, and you want to avoid GA in severe COPD or other patients. You still want a good imaging. Transesophageal echo becomes difficult because it interferes with your valve deployment, as well as you need general anesthesia through the procedure. So to negate that, the best option is to have intracardiac echo along with your TAVI procedure. So this is a 70-year-old multiple comorbidities, coronary disease, cerebrovascular disease, peripheral vascular disease, chronic kidney disease, as well as previous tuberculosis, obstructive airways disease. So you don't want to ventilate this patient. You want to complete the procedure as much as possible under conscious sedation. But at the same time, you do not want too much interference with the TE or transthoracic was difficult. So here we opted to have the intracardiac echo as the choice. It is severe aortic stenosis, valve is 0.6, very high gradients. So left side double puncture, pacing wire and intracardiac echo was placed. Right side was the working access. And that is the valve. And it is 5 meters per second. It is severe stenosis. All the parameters were suitable for a 29 valve. Perimeter is 76. So we opted for a 29 evolute. And the access were all suitable for that. So I'll skip this routine kind of CT assessments. Coronary heights were good, angle was good, 48. More than 70 makes it difficult with the self-expanding. So left side, as I said, artery and as well as left side double puncture, one for pacing and one for the intracardiac echo. Right side always fluoroscopy and ultrasound guided, as Haim has already alluded, both should be used. Aortogram and the gradients you can see. So this I've already mentioned, the advantages of having the intracardiac echo. These are the different ones available. The best one is the AccuNav, and that is there. So basically you go into the right atrium, you get the home view. That is a home view, the right atrium and right ventricle. And then you can sweep through the clock face and you will get the aorta. And once the procedure is complete, you can go into the RV, inflow and outflow, and look at it for your short axis view. Now we have got an expert, Shiva is sitting there. I think after this talk, Shiva will tell us how we can use or maximize the advantage of this intracardiac echo, because he uses it routinely for his congenital cases. And this is the view I said. You go into the RV and you can see from the bottom and you will get a nice sort of aortic short axis view. Or you can go high up into the atrium and flex it anterior like we did last week in one of the cases. And you will get beautiful images. You will get images for left-rated appendage closure. And this is the RV outflow view, which gives you the aortic short axis and the pulmonary artery views as well. So this is what is done. And this is an image of the transcatheter valve. And this is the live image of that particular case. We parked the catheter where we see the aortic valve and the ascending aorta in the long axis view. And throughout the procedure, it was continuously monitoring and continuously showing us what we are doing. So that is the ICE catheter. It will not come in your field in terms of the valve implantation. Otherwise, the procedure was straightforward, right femoral access, 12 French, upsized to 16, crossed, and the confida wire was placed. The procedure was very elegantly done by Sridhar sir. And we have a fantastic, Vikram sir is there. He is the EP consultant who helps us with the intracardiac echo sunshine. And the ballooning with a 20 and then a 29 valve evolute was implanted. Again, a depth was around 0 to 1. And in one view it looked it's constricted, but the other view it looked open. But the hemodynamics suggested the gradient was less than 10. And you should not be fooled by the fluoroscopic appearance of needing to do more. If your hemodynamics suggests it is less than 10, please don't do anything. Because you will have one view showing a different kind of morphology, and that doesn't affect as such the performance. And everything was removed in the end. TPI, ICE, everything was removed. And the patient did well and was discharged on third day. And that is the Transcatheter. So thank you all, and thank the Sunshine Hospital team and Sridhar Kasuri sir for this opportunity and for continuing to having me for the cases there. Thank you, sir.
Beautiful case, and I would like to join the end message. Even if the supraannular valve look kind of deformed or not the frame is not fully open, if the hemodynamics are favorable, no leak, no gradient. You should take advantage of the supraannularity. The frame just find its own place in the, especially in a bicuspid valve, and there is no need, and there is a potential harm in doing a post-dilatation. So once you reach such a nice deployment, don't be fooled by the fluoroscopic appearance. Take good hemodynamic measurements, give some time for the valve to open, take a decent supra-aortic injection, or if you've got the ice, you don't even need to inject, but rather get a good impression of the aortic insufficiency level. And once you don't see so much leak, you're done. You're done. Wonderful case.
Thank you.
Dr. Shivakumar, any comments?
It was wonderful. I was just enjoying all your presentations, and it was amazing. About intracardiac echo, I just saw one glimpse of one image during the live procedure, which I saw was a vivid GE emissions picture. So I assume you had used the Siemens Acunav catheter.
Yeah.
Now the only two intracardiac echoes that are available as of now in our country are the Siemens Acunav as well as the ViewMate Z from the St. Jude. ViewMate Z from St. Jude is compatible with the CX50 of the Philips platform, and the Siemens Acunav that you were showing was compatible either with the Siemens machines or with the GE machines. The while it obviously the slide that Dr. Anantharaman showed discussing the advantages and the problems of transesophageal versus intracardiac echo. One of the problem in our country is the reuse of these catheters. It is being sold at a cost of somewhere close to about 1.8 to 2 lakhs per catheter, and hence we need to reuse these catheters for cutting down the ultimate procedural cost. And so when we are doing a valve implantation procedure, a very, very subtle concern that will come into our mind about the sterility of that particular probe, whether it has gone through the proper ATO to the best possible extent. And so this is one of, because in valve procedures we tend to be extremely cautious about every tiny bit of things that we are using, and so that may be a very, very subtle point of that the interventions may have to think about. And the second problem is, if we are reusing more than 5-6 times, that image quality tends to be little suboptimal. Maybe it is good for a 2-dimensional picture, but when you switch on the color, very often there are quite a few artifacts that we may not be very happy. But I suppose it's a very good technology. We have used it for the last about 11 years. Slowly we are withdrawing away from the intracardiac echo nowadays because of the high prohibitive cost, inability to re-sterilize many times, and this results in escalating the cost of the procedure. But I should not look like a person who is discouraging a new technology. So I would say it's good to practice an echo imaging which does not involve where the patient is very comfortable. It's a very useful technique.
Undoubtedly, your points are very valid. Actually, the particularly valvular, these chance of getting sepsis, these are all really very valuable points. But because the clarity to avoid general anesthesia, many times we are taking a proper precautions. But as of now, we have not faced almost. Myself and Anant together, we did almost 5-6 TAVRs with intracardiac echography. But resolution, as you mentioned, when you are connecting simultaneously 2D echo and ICE simultaneously, these color artifacts are coming like a zigzag pattern, where the black and white images are very good, but simultaneously when you connect the 2D echo and when you are acquiring the ICE, but when you disconnect the 2D echo, many times the color image is very good. So that we notice. That's the reason when we, particularly when you are doing live transmission also, that one of the problem what we are facing. That time we will ask them to just to switch off the other system, only start the ICE. With that one, the color imaging good, then the clarity is much better. And of the system, particularly when you while doing the case, this problem is there. But once you record it, you can see the nice images. But what we want while doing, we wanted better images. This is the problem. But really, beautiful comments as usual, because you are extremely talented, and these points are definitely valid. Doctor, anybody else wants to comment? Otherwise, we'll conclude.
One more comment.
Yeah.
ICE is wonderful, and I'm using ICE mainly for PFO closure and left atrial procedures. I think that it's nice to have during initial cases of TAVI. TAVI currently is a fluoroscopic guided procedure. Echo should be, and I think transthoracic is enough and should be reserved only for those cases of hemodynamic compromise. Once you're towards the end, we're always in a learning curve, but when we feel confident with the TAVI, keep doing it under fluoroscopic guidance, have a transthoracic available, and move ahead. And I'd like to thank the organizers for inviting me. It was a wonderful session, wonderful afternoon in Israel, wonderful evening in India.
Thank you very much, sir. Pleasure is ours. So let me conclude. I thank all the speakers, especially Dr. Rahul Gupta, Dr. Manik Chopra, Dr. Denenberg, Dr. Anantaraman, and Dr. Shivakumar. I also thank all panelists from the bottom of the world, especially Dr. Shailendra Singh and Dr. Vijay Kumar Reddy. I think I learned many things through your beautiful lectures. You illustrated very nice cases, especially Dr. Denenberg showed very beautifully how to fracture the bioprosthetic valve. These are all very important lectures. Even Shivakumar showed very nice images. Anantaraman showed beautiful case. Thank you very much. And with this note, I will conclude, and I will wish you all a great night. Thank you very much.
Thank you.
Thank you, Dr. Sridhar. Thank you, everyone.
Good evening.